Please welcome to the stage Vice President for Health Policy, the American College of Obstetricians and Gynecologists, Barbara Levy.
It is such a pleasure to be here and to share with you what the American College of Obstetricians and Gynecologists is committing to the Patient Safety Summit, but more importantly to the patients of this country and of the world. As devastating as 200,000 deaths are a year, the death of a mother is profoundly devastating. That one death in the most exciting time in someone's life, for a husband, a partner, to take home a child without a mother is not right. And what we know is that there is preventable maternal mortality in this country, and we are committing to moving that along. What we know is that we cannot do that alone as a professional society, that it does take a village, as Hillary Clinton would say, but that we need partners with healthcare systems, with hospitals, with anesthesiologists, with neonatologists, with nursing, nurse midwives, facilities, birth centers. We need the help of the pathologists, the blood banks, to make this work. This is not just physicians deciding that we're going to make a change. The cultural change for this has got to be all of these groups together. And what ACOG has done is, by recognizing that, we've convened a patient safety council. And it's a council made up of all of these people that are so critically important, working together towards the end game of decreasing mortality. But in addition to working with our professional colleagues, we also have to work with industry. We need the support and the collaboration with industry to make this happen, and to do that, we have industry forum associates with our Patient Safety Council. But here's the problem. The problem is that as much technology as we have and as much tertiary care medicine as we have in this country in 2014, the numbers of deaths are increasing every year, as this slide will tell you. And it's not only intrapartum, but it's postpartum. We're going in the wrong direction, ladies and gentlemen, and that's unacceptable to ACOG, to my colleagues. One of our problems, as was articulated earlier, is that 2/3 of the facilities in this country that deliver babies deliver fewer than 1,000 babies a year. So while it's lovely to have big institutions represented here, we need to have a system in place that can be brought to the small places, to the places that will never see a maternal mortality for 5 years. What can they do? What can we help them do to recognize and prevent that devastating outcome? What we know is that the causes of maternal mortality are many. About half of them are preventable, half of them are indirect. They're related to gun violence, intimate partner violence. And ACOG is working on those things at an advocacy level, but what we're focused on here today is what can we do to prevent the medically preventable deaths. And this is a busy slide just to say that what we've done is identify the 3 major areas that we can impact quickly to make this commitment to all of you. And those are hemorrhage, venous thromboembolism, and hypertension or preeclampsia. Those are 3 areas in which the recognition that a woman is in trouble is delayed. And it's delayed because we're fortunate, in my specialty, we're taking care of relatively healthy and quite young women. So women will not show those same vital sign changes at the same time as others, as the elderly will, as the people that are in the ICUs. And of course, they're not in an ICU setting. They're on labor and delivery, or they're in a birth center someplace where they don't have the same staff available. And as much as we're talking about 300 to 500 deaths in this country every year, we are talking about 400,000 deaths globally. We are talking about more than 1 death per minute of a mom in this world. Those deaths are preventable, and they are just the tip of the iceberg. When you look at the morbidity statistics, that is really where we can impact patients and families. As I was working prior to coming to ACOG, I had a colleague who was just thrilled with the pregnancy of his wife. They were both physicians. They were pregnant with twins. And about a week after the delivery, he came back to the hospital in tears with his twins, talking about the unfortunate death of his wife, our colleague. As rare as maternal mortality is in any institution, those stories cannot, should not happen. These things are preventable. So what are we doing? How are we going to do this? We're putting out 3 bundles in 3 years. A bundle is a care package. It is not only the checklist, but it's all of those other things that have to be in place for a small facility to be able to understand, recognize, and act quickly to resolve the situation. We understand that a tertiary care center and a very small hospital in rural Minnesota will have a different mechanism to implement the bundle. But what we are putting out is what factors must be in place for each one of these bundles. We will not tell a hospital, and in fact, a culture will never change if ACOG comes down from on high and says, you've got to do it this way. We need the buy-in of everyone on that unit, everyone working together in that institution. And that's what the purpose of these bundles really is. It's to tell them what they must have in place. They have to have a hemorrhage kit that's got all the drugs and all the things all in one place. They've got to have a mechanism to engage the blood bank, because unlike cardiac surgery and other situations where you could anticipate the need for blood, when a woman starts hemorrhaging postpartum, she can need 30, 40, 50 units very quickly. And whereas in a tertiary care center that can happen, it's awfully difficult to make that happen in a rural setting. And unlike the neonates, we are not in a position to transfer that patient. So the bundles are about providing the tools and the opportunity for each institution, each delivering facility, to call it their own. And we think that that's critically important. So those key elements are a risk assessment of a patient prior to her delivery time, prevention when possible, recognition of what's going on, utilizing and mobilizing resources, understanding when that needs to happen, and then very importantly, debriefing. Not debriefing after the death, we hope, but debriefing after the near miss, after the severe morbidity. And I have to thank the Joint Commission, because one of the things that we recognized early was that changing that culture is indeed incredibly difficult. And what has to happen is that we need some carrots, but we need a lot of sticks. And the Joint Commission, working with us, has helped us to develop a definition of severe morbidity, which is transfusion of 4 or more units and admission to the intensive care unit. That will be rolled out by the Joint Commission as a sentinel event, and we are also providing all the tools for any institution to be able to report that to their state, to the Joint Commission, to any other entity that requires reporting, so that we're taking what's right and making it easy. Because in the end, the cultural change will not happen if it's too hard to do, if it's too difficult. So the achievable results, we think we can get a reduction of 50% in maternal mortality, of the preventable causes of maternal mortality. But more importantly, we can avoid hysterectomies, the severe morbidity, all the serious things that are happening to women when they don't die. Because for every death, there are 20, 30, 40,000 episodes of severe morbidity. That is our commitment. We want to achieve that, not by 2020, Joe, but in the next 3 years. Thank you.